GLP-1 agonists are pharmaceuticals that activate the GLP-1 receptor, which is involved in glucose regulation and insulin processing. It's a pretty big class of medications. People think they're new, and providers who aren't really familiar with them or have heard horror stories have a lot of hesitancy, thinking they're like some sort of new drug out there. They've been around. The first one was approved in 2005. So they've literally been in use in humans on a large scale for over 20 years. So this is not a new kind of drug. It's just exploded recently with certain regulatory things that happened during the pandemic that have allowed them to get into the hands of many providers and even people without a provider. And it's really the most effective thing when it comes to weight loss that we've ever had in the pharmaceutical industry. I think what providers miss is really the big picture, because there's been this huge explosion and open access to these drugs. Everybody just wants the drug, and they want the quote skinny shot, and they want the easy way out when it comes to weight loss. But you can really outeat any drug, workout regimen, whatever you're trying to do for weight loss. And I think also because they are a revenue stream for practices for the most part these days. And what a lot of people taking GLP-1s don't understand is that whoever's selling you the drug makes more money the more you take. And so there's just no threshold to increasing doses, which I think is not in the best interest for the person using the peptide. And you miss the whole picture of the environment. It really requires environmental change to be most effective. And if you're just going to take the shot and continue to eat whatever you want and not exercise and be stressed and have poor sleep, then you're never going to be able to come off the drug, and you're going to require more and more and more for the same effect. And in the end, that's just really not serving a good purpose. And I think, especially in my area, most practitioners are just handing these things out like candy. And if it's not working well, we'll just take more. And it's hurting people. And that's not really an appropriate way to permanent change. I think if you're not certified in peptide therapy, or at least medical weight loss, where you've had higher level training on the peptides, you may or may not really understand all the intricacies of getting people on them, escalating therapy, de-escalating therapy, getting people off if that's their desire. Also, through my peptide certification, and I'm also certified in medical weight loss, I learned a lot of adjunctive therapy in addition to the GLP-1s. And nobody comes to me as a patient knowing anything about these other peptides or supplements or things that can be helpful, either to make the GLP-1 more effective if it's not working really well in you, or just adding additional support, like through growth hormone support for building lean muscle, which is an excellent adjunct to a GLP-1 agonist, since any weight loss program results in a lot of muscle loss. About a third of what you lose through any plan, whether it's a GLP-1 or you're just going to Weight Watchers, you're going to lose muscle if you lose weight. And so augmenting that and offsetting that with other peptides can be really helpful. And I think just your standard, provider that doesn't really have higher level training, they don't know anything about that. They just prescribe a GLP-1, and if it doesn't work, increase the dose. And if that doesn't work, then you're on your own. So you get the whole package with me. I understand how to make the peptide most effective and find a dose that works for you without giving you so much you'll never be able to come off the peptide. I have other tools in my toolbox that we can use to help maintain you on the lowest effective dose. You also can get weight loss through my program without a GLP-1. If it doesn't work for you or you just don't want to engage in that therapy, it's a full comprehensive weight loss program. Everybody gets a meal plan. They get macronutrient calculations. They get an exercise prescription. We have discounted rates for body composition testing and resting metabolic rate testing so that you can track your progress and make clear goals. And most important probably is we have a functionally certified health coach who can help you implement change in your life, which ultimately will be essential for you to meet your goals and to make lasting and permanent change. So that if you're on a GLP-1, you can ultimately come off or come down to the lowest dose possible. A lot of people come to me and they're like, oh, I know what I need to do. But the reality is people don't know what they need to do. They think they need to eat low fat or they need to spend an hour and a half a day on a treadmill. Both of those things will work against you if you're actually trying to lose weight. And so there's a lot of education handed out in my program to help people really understand and implement lasting and permanent change in their lives. Sometimes I find that this really is two factors that contribute to this. One is, did you make lasting and permanent change in your lifestyle? If you didn't, then you're going to end up right back where you started or even worse. The other factor is how much GLP-1 are you on when you stop? And so we talked a little bit about how providers will just keep increasing the dose and increasing the dose. And if you're on a very high dose and you stop it suddenly, then you are going to rebound and gain a lot of weight. And it can actually happen pretty quickly. And it can happen even if you're eating the same amount of calories or the same food composition that you were, and you're maintaining your weight. Say, you've achieved your goal and you're maintaining your weight for 2-3 months and you're like, oh, I want to stop this. If you're on the mid to high dose of whatever GLP-1 agonist you're on and you stop cold turkey, your receptors have no idea what's going on. And these are very potent medications. So even at the lowest pharmaceutical dose, the receptor is activated about 1,000-fold above what it would be if you're not on the medication. At the highest dose, it's 10,000 times more activated or more than when you're not on it. And so you can imagine your receptors have no idea what's going on when they're 10,000-fold activated to 1% activated, And so your glucose regulation becomes very dysregulated. Insulin levels can go very high. High levels of insulin cause adiposity and gaining of adipose tissue, which is basically fat. And so there are reports of very rapid weight gain. There's only been one study that I'm aware of that's actually published how much weight do people gain. And it was roughly 30% of what they had lost over the 3 months after stopping the medication. In my practice, people have gained all of the weight back if they're, still eating fast food and not exercising. Then you're going to go back to right where you were and maybe more quickly than if you had never been on a GLP-1. There are ways to responsibly come off it. That's why I always try to use the minimal effective dose to achieve the goal. And my goal for weight loss is usually roughly around 1 pound per week. Anything faster than that makes regain much more likely. And it also makes the loss of muscle much more pronounced. And so people get very greedy. Again, these drugs can be incredibly effective. And if you've dropped 5 pounds in the first week, then suddenly you're like, oh, well, I want to get these extra 20 pounds off in the next month. And that's just not healthy. And you're much more likely to rebound. If you're very slowly losing, 1 pound or 2 a week, depending on how excess you have to lose to achieve your goal, it's going to be a lot easier to maintain that. I do a very slow wean off the GLP-1s. If somebody does want to come off, I actually titrate off slower than I titrate up in the beginning when we're trying to find an effective dose. And that gives the receptors a chance to kind of re-equilibrate to having less GLP-1 agonist on board and find their new baseline. And so it can sometimes take months to come off the drug in people who desire to. Yes, for my practice, your maintenance dose is your lowest effective dose. And so typically, once people have achieved their goal, I want them to play around with the peptide and find how little can you take to maintain your goal. Are you able to come off? Great. And this is specifically for weight loss, by the way. And so if people say they're on 5 milligrams of tirzepatide to achieve their goal, then I'll have them very slowly over several weeks come down on their dose so that maybe they can take 2 milligrams every week and not gain weight. How little can you get away with and not gain weight? And it's not like you're going to pack on 10 pounds in a week. And so it's subtle and you need to pay attention over time. And so usually I'll have somebody on a set dose for 3-4 weeks before they decrease even further to see, did you gain weight in 3 to 4 weeks? If you did, and you weren't like on vacation, you're living, your best life and following all the rules that you're going to follow for the rest of your life, then maybe you can continue to come down. But I have a lot of people that are on maintenance GLP-1 agonists that have achieved their goal and they just don't want to come off because it's easier to stay on and maintain your goal, basically. I don't think there's any long-term harm that we've seen in 20 years of using this drug. We only continue to find more and more benefits with more diagnoses that can be successfully managed with this class of drug. So I don't think that 20 years from now, we're going to suddenly discover that the drug caused cancer or dementia or something. I think it's quite the opposite. It's just going to find more and more benefits. So I'm not opposed to somebody staying on a low dose long term if they choose to. So you need to clean up the terrain. You should be eating a whole foods diet, mostly plants with some responsibly sourced meat. You do really need to maintain your protein intake while you're in an aggressive weight loss phase, but not overdo it. A lot of influencers and people in the muscle building space right now are really promoting much higher levels of protein than are necessary. In that, you can find hours and hours and hours of podcasts debating the protein issue. But I would say a minimum of 1 gram per kilogram while you're in your weight loss phase so that you can support your muscle. But you can eat 100 grams of protein a day. And if you're not lifting weights, you're just going to be storing it as fat or added glycogen, which will make it even more difficult to lose weight. And so you really need to be doing some resistance training and meeting your minimum protein requirement to avoid significant muscle loss. And you need to be making lasting, lifelong, permanent habit change so that you can be successful. No, obviously, they've taken storm. There's a huge GLP-1 agonist storm for people that want to lose weight. They were originally designed for diabetes, and then the quote side effect was weight loss, and that's how they came into this space for weight management. That actually is not uncommon in the pharmaceutical world. It's developed for one purpose, then they get some other thing that they weren't expecting during a trial, and then the pharmaceutical industry is like, oh, well, let's try to make it work for this, and then they get a new label for it. So they work well for weight loss. There's some new data that will be coming out soon, I believe, in regards to decreasing cognitive decline. I suspect that's because blood glucose is very well modulated by the drug, and glucose causes dementia. And so I think that most of the changes are really because there's less sugar in the bloodstream, and sugar really causes a lot of problems. They seem to be pretty potent anti-inflammatories. I believe there are trials ongoing right now in the autoimmune arthritis space. I know personally I've had patients that have gone on these medications for weight loss, and the entire time they're on them, they have no joint pain from their psoriatic or rheumatoid arthritis or whatever autoimmune arthritis they suffer from. And so I think there is some investigation going into that. There's not the only FDA approved indications currently are diabetes and obesity, but the drug has a lot more effect than that. It is very good for insulin sensitivity and glucose modulation. No, there are a handful of GLP-1 agonists. And again, they've been, available since 2005. And there have been a lot of iterations of them. The ones that were in use in 2005 are actually not even available anymore. They used to be daily injections. And thankfully, the pharmaceutical industry figured out a way to make them weekly injections. They're currently I can't remember the generic name for Trulicity, but Trulicity is still available. It's a lot less utilized than Ozempic, which is semaglutide. So the three main ones currently in use are semaglutide, tirzepatide, and then on the horizon is retatrutide. It's not mainstream yet. It's not yet FDA approved, though you can get it sometimes. It is available. But not as a pharmaceutical yet. They're finishing up the phase 3 trials for that one. And so the difference is that semaglutide is just a GLP-1 agonist, and so it activates only one receptor. Tirzepatide activates two different receptors, GLP-1 and GIP, both involved in insulin signaling and glucose processing. And then retatrutide, the one on the horizon, activates a third receptor as well. And so with each receptor, the drug becomes a little bit more effective and may have less side effects. There are side effects. Not everybody can tolerate them, and most of the side effects are GI in nature. And so the newer the drug is, it seems the better it's tolerated and the more effective it is at both weight loss and glucose reduction. So they are not all the same. So side effects for GLP-1s, it is important to touch on those because these are obviously what prevents some people from being successful on the medication. They're most commonly GI. So the drug works in a couple of ways for weight loss. Not only does it make you more sensitive to your insulin so that you can secrete lower levels of insulin, which promotes weight loss, but it also is a very potent appetite suppressant in the brain. It kind of shuts off the food noise, which can be a huge game changer for weight loss if you're not constantly thinking about what is going to be your next meal and, oh, I really, want that candy bar or the piece of cake or whatever. Shutting off the food noise is super helpful. But it also delays emptying of food from the stomach. It delays gastric emptying. And this can be very profound. And it helps with weight loss in a lot of ways. One, it makes you nauseous, and nobody feels like eating when you're nauseous. And so nausea is a very common side effect. It typically goes away with repeat dosing at the same dose. So if you're really nauseous the first time, you might be a little less nauseous the next time, and then it can go away altogether until you increase your dose. Then you might be a little nauseous again. The gastric emptying stays. And so you eat less, and you learn very quickly that the amount that you used to eat is not the amount you want to eat now, because you'll feel like you ate the entire Thanksgiving turkey and it's very uncomfortable. And even that can make you nauseous. You may throw up. And so meals become much smaller because you learn that you're going to feel horrible if you don't make that adjustment. And so those are really the big side effects. It can contribute to constipation. And so if you're somebody who really struggles from constipation, they might not be the best choice for you. Oddly enough, they can cause diarrhea because the gut's trying to work overtime to kind of make up for the slowing, and then that can cause diarrhea, but constipation is much more common. And so these are, I focus all of these side effects, focus on them in my practice too. I don't want somebody to be constipated, because if you're not eliminating, that's the quickest way to gain weight. If you have 20 pounds of stool in there and you're not getting it out, then you're really working against yourself for your goals. And so we focus, take into account all of the side effects as well from the drug. I love continuous glucose monitoring. It is so educational for a patient to see exactly what happens to their glucose when they exercise, when they get poor sleep, when they eat that, I'm just going to cheat this one time. I use this a lot in my practice, and mostly for non-diabetics. In my practice, let's be real, I'm trying to prevent diabetes or reverse diabetes, and I am more often trying to prevent it. Thankfully, my patient population, for the most part, tries to get to me before the horse has completely left the barn. But the CGM is great for diabetics as well. It's just super helpful for non-diabetics who have insulin resistance or even pre-diabetes, and we're working very hard to prevent becoming overtly diabetic. So a CGM, for those who do not know, is just a small device that you wear somewhere on your body, most commonly on the back of your arm or on your belly fat, or you can wear it in your gluteal region. And it's just usually a small device, and it has this tiny filament that goes in the tissue right under your skin, and it measures your glucose levels about 220 times per day without having to, do that finger stick thing that is the way we used to measure glucose a couple of times a day. And so you get real-time information with every meal, when you exercise, again, with sleep. I use it for patient education purposes. The CGM trial that I offer is a 15-day where I use the Dexcom sensor, not to throw out, proprietary names. I get no compensation for Dexcom, but their sensor is definitely the most accurate and reliable sensor. And then my service comes with a health coaching visit where a patient is required to write down everything they put in their mouth for 10 days while they're wearing it. It's not very helpful if you're not keeping track of what's going on. I ask them to tell me when they go to sleep, when they wake up, when they're exercising. And so we can correlate glucose spikes. We look at fasting glucose. We look at 1 hour, 2 hour, and 5 hour after you eat. And there's certain optimal metrics of where you want the glucose to be at all of those times. And so it can be very educational. And if somebody doesn't do it, you can't always know. You can know, like, if you eat a piece of chocolate cake, your glucose is going to go up. But there are different spikes. Like, some people spike with red wine and some people don't. Some people spike more with rice than they do with sugar. Some people don't. And so it can become very helpful in knowing what foods to avoid and just reinforcing what happens when you are constantly providing your body that carbohydrate load. I put most of my pre-diabetic, diabetics, insulin-resistant patients, people with diabetes into nutritional ketosis because that's how you can reverse that whole process. All of my weight loss patients also need to be in ketosis. And so this is where you're burning fat for fuel, not carbohydrates. And it's a very common belief that, every 4 or 5 days you can eat that hamburger bun. And the reality is you cannot, because it will refill your glycogen bucket and it will take that many more days to empty the bucket and get into ketosis. And we measure ketones as well. I'm waiting for the continuous ketone monitor to come out. That will be a game changer for people. But what the CGM allows people to see is why their fasting glucose doesn't come within optimal range when they feel like they're being compliant with their meal plan, except they cheat a little every 3 to 4 days, and it can prevent reversal of insulin resistance. And so it's just really helpful to see that real-time data of what's happening based on what you're eating and doing.